Hi, I'm Javier Castellanos, and I have the pleasure of introducing the Symposium on Rewiring the Restless Brain, Variability in Translational Neuroimaging and Attention Deficit Hyperactivity Disorder, which is part of the first virtual symposium held by the Society of Biological Psychiatry on its 75th anniversary. I suspect this will not be the last SOBP symposium to occur virtually, but it's our honor and our challenge to bring this information to you. I'm particularly honored to be part of this and to introduce to you the next generation of leaders in understanding brain development in neurodevelopmental disorders, in particular attention deficit hyperactivity disorder. And so for the next couple of hours, we'll be reviewing some of the work that these extraordinary young investigators have been conducting. And I want to alert you to look out for them because they truly will be driving the field forward over the next decades. So we've been at this business of neuroimaging and ADHD for now almost 3 decades. And we've made some slow progress, but we've yet to impact clinical practice in any reasonable way. Particularly, we're still quite ignorant about the mechanisms of action of the treatments that are quite broadly used. And so we're glad we have them, but we don't really understand how they work or how to make them better. Here, we bring together early career investigators from the US and Europe who have been working on these kinds of questions using primarily functional MRI methods and with a focus on inter-individual variability in regards to treatment response, age, and developmental stage. We're going to hear about both task-based and resting state approaches. Arterial spin labeling is being used in pharmacologic fMRI approaches, incorporating both males and females, children and adults, and focusing in this case on the most commonly used medications, methylphenidate, amphetamines, and atomoxetine. These are the introductions, and we'll hear from Anouk Cubillo, Anouk Schrantee, Jessica Cohen, and Victor Pereira-Sanchez in that order. We hope that you'll stay with us for a roundtable discussion at the end. And as I said, that this will be seen as really a pivot point in the next generation of ADHD functional imaging research. This symposium chairperson, although I have to say that Victor Pereira-Sanchez has done almost all of the work, so I appreciate his involvement and really driving this forward. I'm at the Department of Child and Adolescent Psychiatry at the NYU Grossman School of Medicine and the Nathan Klein Institute for Psychiatric Research. And I have no conflicts of interest for this presentation, although I do consult to a company that is seeking to market cannabis-based medications, and I receive medication from Epidiolex, medication from Greenwich Biosciences for palate study in autism. Our speakers are young investigators from Europe and the US, and I won't go through each of them here, but I'll tell you about them individually. Hi, our first speaker will be Anouk Cubillo. Dr. Cubillo is a senior researcher at the Zurich Center for Neuroeconomics at the Child and Adolescent Psychiatric Department at the University Psychiatry Hospital in Basel. Her current research projects investigate the factors affecting the development of self-regulation processes, both in typically developing children as well as in clinical populations, together with potential avenues for intervention. After training as a clinical psychologist in Spain, she was an Alethea Koplowitz Foundation Fellow at the Institute of Psychiatry, King's College, London, working with Professor Katia Rubia. During her years at the IOP, she collaborated on multiple projects, mainly focused on the persistence of ADHD into adulthood, the disorder-specific character of their dysfunctions, as well as on the behavioral and neural underpinnings of the effects of stimulant medications on children with ADHD. It's in this field that she obtained her PhD, with a large project comparing the neural effects of stimulant and non-stimulant medications in children with ADHD. We're thrilled to have Anna as part of our panel, and in particular, she represents one of the senior and the most successful alumni of the Alethea Koplowitz Foundation, And she and Victor will be bookends because he's one of the most recent appointees to that prestigious fellowship. So with that, I will turn the podium over to Dr. Ana Cubillo.
So thanks a lot, Javier, for the really kind introduction. And above all, thanks for the invitation to be part of this symposium. This is a great honor and a pleasure to be part of such a fantastic panel of speakers today. And I would also like to thank to the Society of Biological Psychiatry for the opportunity to deliver the symposium online, making it possible despite the current situation. And as you can see from this first slide, and also Javier has already said, my current affiliations are at Swiss University, but I will be talking to you about some recently published data, which is part of a much larger project that we conducted at the Institute of Psychiatry, Psychology and Neuroscience at King's College in London. And the main goal of this project was to provide some light on the compared mechanism of action of two of the most commonly prescribed medications to treat ADHD. Oh, and now I need to. Oh. Okay. So this is my conflict of interest, which is none, as you can see. And as we all know, attention deficit and hyperactivity disorder is a highly prevalent and severely impairing neurodevelopmental disorder. And one of its defining and most prominent characteristics are the attention difficulties, which in daily life we can see that our children who are forgetful, are easily distracted, they have difficulties in organizing tasks or activities, or they avoid tasks that require sustained mental effort. And we can measure these difficulties in the lab, for example, by using sustained attention tasks. And indeed, poor concentration and performance on these tasks are one of the most consistent behavioral and cognitive deficits reported in patients with ADHD. And brain imaging studies have indeed shown that during sustained attention tasks, patients have reduced activation compared to controls in a group of regions typically described as components of the sustained attention networks like the middle prefrontal cortex, the parietal lobe, or the basal ganglia. And some of these dysfunctions have actually even shown to have a disorder-specific character. Because, for example, when we compare this to the dysfunctions that we can observe in patients with autism, for example, that we know that very often also present difficulties during sustained attention processes, we can actually see that it is only the group of children with ADHD that are showing the reduced activation in middle prefrontal cortex or the enhanced activation in the precuneus that we know is part of the default mode network whose dysfunction has been suggested as potentially underlying the attention lapses that are frequently described in ADHD patients. It is therefore no surprise that pharmacological interventions aim to improve such attention deficits. However, when the clinician has to make a decision about what medication to prescribe to the patient that he has in front of him, they have relatively few data apart from the guidelines, which typically recommend to start with methylphenidate unless there are contraindications to do so. And once this is started, either because of the medication is not effective or because the patient is not well tolerating the medication, then an alternative is needed. And a recent meta-analytic study has shown that both methylphenidate and atomoxetine seem to have a similarly well-tolerated side effects, and both for adults and for children and adolescents. And also both of them are effective, more effective than placebo in the treatment of symptoms of ADHD. Very similar effect sizes in the case of adult populations, and also more effective in both cases for children and adolescent population, but a slightly stronger, larger effect size for methylphenidate. And therefore, methylphenidate remain being the stimulant medication of choice for the treatment of ADHD. So even though we know that both are effective and both improve attention symptoms in ADHD, how their effects are compared and what their respective mechanism of actions are is still poorly understood. And the fact that there is a large proportion of patients that improve with either of these medications suggests that there is at least a partial overlap in mechanism of action, but also there are differences very clearly. It is indeed known that methylphenidate is an indirect catecholamine agonist that blocks the dopamine transporter in the striatum and the norepinephrine transporter in prefrontal regions. On the other hand, atomoxetine is a non-stimulant that is more selective for norepinephrine transporter and has lower affinity for the dopamine transporter. And it is therefore expected that both medications will increase extracellular levels of dopamine and norepinephrine in prefrontal areas, but only methylphenidate will increase the levels of dopamine in the striatum or the nucleus accumbens. And despite the fact that attention difficulties are at the very core of the disorder, there are few studies that have actually focused on the impact of pharmacological interventions on performance or on brain activation during sustained attention paradigms. And one of those studies is coming from Bedard and colleagues, and they use a within patients crossover design in previously medicated children with ADHD to investigate the compared effects of methylphenidate and atomoxetine treatment on performance measures during sustained attention. And patients received 4 to 6 weeks of each of the compounds with doses that were titrated to their optimal ranges for each participant. And they showed that it was only after administration of methylphenidate that there was a significant improvement in the performance in the task. As you can see, the reduced number of omission errors, the reduced mean reaction time, or the reduced reaction time variability in their responses. However, this is in contrast with a more recent study from Nee et colleagues. In this case, they recruited adults with ADHD and they performed a between group comparisons, where adults received 8 to 10 weeks of treatment with either methylphenidate or atomoxetine, also again titrated to the optimal doses for each participant. And they perform a sustained attention task before and after the treatment. And the main performance measures in this case is the intra-individual variability of reaction time, which has been suggested as a potential endophenotype for ADHD. And to investigate this, they use an X-Gaussian model that accounts for the fact that the reaction time distribution tends to show a positive skew due to infrequent but very slow responses. And the authors show that when you look into this tau component, changes suggest that both medications have comparable effects. And using a sustained attention paradigm, a group has previously shown that a single dose of methylphenidate on medication-naive children with ADHD could partially normalize the activation deficits that were seen when patients were under placebo, as you can see here in temporal and parietal regions, and these were partially normalized. But the most interesting part of this was that together with this partial normalization effect, we see that the functional connectivity deficits between the different regions integrating the sustained attention networks were lower when patients were under placebo compared to controls, but were almost completely normalized when patients were under a single dose of methylphenidate. So methylphenidate is able to enhance functional connectivity between the key regions in the sustained attention network. And as I mentioned in my first slide, our group conducted a large project, which is a head-to-head comparison of the effects of acute single-dose administrations of methylphenidate and atomoxetine on different cognitive functions. On cognitive functions where ADHD patients typically show deficits, both in performance and on brain activation. And this project has a within subject design in which patients received either a single dose of methylphenidate, atomoxetine, or a placebo, and were scanned on 3 consecutive weeks while performing the relevant paradigms. And one such paradigm was the stop signal task, which measures the motor response inhibition. And we know that patients typically present with difficulties when they have ADHD. And in this case, when patients were under placebo, you can see that they have reduced activation in key regions for inhibition, most relevant in the bilateral ventrolateral prefrontal cortex, inferior frontal regions. That these activations deficits were almost totally normalized in the case of frontal regions by the administration of methylphenidate, and also significantly normalized by atomoxetine, in particular in the left ventrolateral prefrontal cortex. And this is consistent with what we see in the within subject analysis, where we see that within patients, in a single dose of methylphenidate is able to upregulate activation in the key region for motor response inhibition, which is the right inferior frontal cortex. In this case, the cluster is bordering the superior temporal gyrus. Patients also performed the temporal discrimination task, and in this paradigm, case control comparison showed that patients under placebo have reduced activation in typical regions for time discrimination involving the right ventrolateral prefrontal cortex, as well as the dorsal anterior cingulate and extending to the supplementary motor area. And we see that when patients were both under methylphenidate or under atomoxetine, these deficits in the right ventrolateral prefrontal cortex, they are no longer observed. It is normalized by both medications. And this is consistent with the results from the within patients analysis, where we see that both the single doses of methylphenidate and atomoxetine are able to upregulate activation in the right ventrolateral prefrontal cortex relative to what is observed when they are under placebo. However, when we look into this cluster of dorsal anterior cingulate and supplementary motor regions, we see that it is only methylphenidate that is able to partially normalize the deficits observed there. Finally, we also looked into the compared effects of single doses of methylphenidate and atomoxetine on working memory. And this is a cognitive functions where we know that patients with ADHD typically present with difficulties, and that has even hypothesized to possibly be at the core of the disorder. And compared to healthy children, medication-naive boys under placebo saw reduced activation in the key working memory region, the bilateral dorsolateral prefrontal cortex. And we see that in the typically developing controls, there is the enhanced expected increased activation with increase in task difficulty on both hemispheres, and this is not observed when patients were under placebo. And we see that this is the same pattern that we observed when they are under methylphenidate, that nothing is normalized in that case. However, the cluster of deficits is only observed in the left hemisphere when patients are under atomoxetine, and is totally normalized on the right lateralized cluster. And this is consistent with, again, what we see in the within patients analysis, where only atomoxetine is able to upregulate activation in the right dorsolateral prefrontal cortex. But what I find interesting in this study is that both medications are able to enhance activation over and above what is observed in typically developing children in areas involving the thalamus, the striatum, the superior temporal gyrus in both cases, and extending to the inferior frontal cortex in the case of atomoxetine. And this activation, we consider it is having a compensatory character because it is associated to better performance in the task in both cases. Okay, so now moving on to the sustained attention task. As I was saying, it is part of this large project, and I just wanted to give you a few more details specifically for the sustained attention task. Again, it's a double-blind, placebo-controlled crossover design, where in the case of sustained attention, 27 typically developing controls were scanned once unmedicated, and 14 medication-naive boys with ADHD were scanned in 3 consecutive weeks when they received in a pseudo-randomized order either a dose of placebo, of methylphenidate, or atomoxetine that were adjusted by weight and were administered 1.5 hours before the scanning session to maximize their effects by the time they were inside the scanner. Of course, we obtained the approval from the local ethics committee, and we obtained also consent and assent from parents and children when necessary. The details about the task that we use, this is a sustained attention task that is a variant of the psychomotor, vigilant, and delayed task, and requires sustained and focused attention. And participants are asked to respond as quickly as possible to the presentation of this visual timer that starts counting milliseconds from 0, and they have to stop it as fast as they can. And this timer can appear after a short and predictable delay of ½ a second. And these are trials that are presented in small blocks of 3 to 5 stimuli. And the timer can also appear after an unpredictable time delay that can be either 2, 5, or 8 seconds. I just put 8 seconds here, but it can be in one of these durations. And the long, infrequent, and unpredictable delays are having a higher demand on sustained attention and vigilant processes, whereas the short, predictable delays can be typically anticipated and having a higher demand on sensory motor synchronization. And the fMRI contrast is comparing the brain activation during the long versus the short delays. Moving on to the results, in terms of performance comparisons, we start with the between group comparisons, and we see that during the sustained attention condition, when patients were under placebo, they are having a longer mean reaction time, a higher intra-individual variability in the responses, and a higher number of premature errors also. And this is not normalized by administration of atomoxetine. The deficits in performance is still being the same. However, when patients were under methylphenidate, we can see that there is a complete normalization of the differences in mean reaction time, and the differences in intra-individual variability and premature errors are reduced and only significant at a trend level. In terms of the sensory motor synchronization condition, we see very similar to before. Patients under placebo have higher intra-individual variability in their responses and more premature errors, and this is not normalized by either of those medications. And this is again consistent with the results from the within patients analysis in performance, where during the sustained attention condition, when patients were under placebo, were having a shorter mean reaction, where patients were under methylphenidate, were having a shorter mean reaction time compared to placebo, but there are no other significant differences between the medication conditions. Moving on to the brain imaging results, we see that in the case control comparisons, patients under placebo have reduced activation in sustained attention networks involving from ventral regions in the thalamus or the striatum and extending to mid-cingulate, anterior and posterior cingulate, also medial prefrontal cortex and parietal areas, as you can see in the figures. And in this case, the increased activation in the control group is also associated to better performance in the task. And I have just highlighted these clusters because here, these are the ones where the association survives multiple comparison correction. And you can see that either of them are associated with increased activation is associated with longer, shorter mean reaction time and reduced intra-individual variability in their responses. And the important thing is that when patients were under methylphenidates and when patients were also under atomoxetine, all these differences disappeared. They're totally normalized by the administration of either of these medications. And when we go into the within patients analysis, we see there are two clusters where the main effects of medication are observed. One is in the left ventrolateral prefrontal cortex and extending to superior and temporal regions. And this is due to the enhanced activation of methylphenidate, which is the only medication that can upregulate activation in this region and is furthermore associated to better performance in the task with reduced intra-individual variability. And the second cluster is extending from temporal regions, middle and superior temporal areas to posterior cingulate and precuneus, and is associated with reduced activation during placebo, and again, associated with performance in the task. So I will summarize the findings. So in the first case, we have that during a sustained attention task, medication-naive children with ADHD compared to healthy children show impaired performance in the task. And they also have reduced activation in sustained attention networks, which are right lateralized from frontoparietal regions, but also extended to cingulate areas, striatum, and reaching down to the thalamus. We have the important results that both methylphenidate and atomoxetine are sharing the effects in terms of normalization, as they are able to normalize the deficits observed when patients are under placebo in the sustained attention networks. However, only methylphenidate was able to normalize the performance differences observed in mean reaction time and reduce the significant differences on intra-individual variability and premature errors. Together with the fact that both methylphenidate and atomoxetine were able to upregulate activation in posterior cingulate or precuneus, and only methylphenidate upregulated activation in the left ventrolateral prefrontal cortex. And to conclude, we can see that both are sharing the effects. Both are improving brain activation in sustained attention networks. However, in the case of atomoxetine, longer administration may be needed for us to see the impact on performance, because we could see that impact on performance only when patients were under methylphenidate. And this parallels what is typically described in the clinics, where patients have to go on to 4 to 6 weeks of treatment to start to see changes in ADHD symptoms. And it has been suggested that you may need to go up to 12 weeks to see full efficacy of atomoxetine administration. We also consider that the drug-specific effects that are left lateralized for methylphenidate on the ventrolateral prefrontal region may be dopaminergically mediated and due to motivation processes, and that the shared effects on the normalizing the right lateralized deficits in dorsolateral prefrontal cortex may be task-dependent and achieved via different mechanisms. And I would just like to finish highlighting some studies that will be following up, are already on the way, are planned, or should be coming up. Obviously, the comparison of longer-term effects of atomoxetine and methylphenidate, the investigation of mechanism of action of neurostimulant and non-stimulant drugs like lisdexamfetamine or guanfacine. Also, as well as the mechanism of action of non-pharmacological treatments for ADHD, like the use of neurofeedback or the use of the combination between non-invasive brain stimulation techniques like TDCS together with cognitive training. And with this, I would like to finish with my acknowledgement to the funding bodies for the study and for my own funding in the UK. My co-authors, obviously to Professor Katia Rubio and Joanna Smith, who supported me throughout the whole project, as well to Olivia Kowalczyk, who supported me with this last portion of the sustained attention task, to patients and participants in the study, and most importantly to Javier and to Victor for inviting me to take part in this symposium and to present this data with you here today.
So let me now take the opportunity to introduce our next speaker, Anouk Schrantee. Dr. Schrantee is an assistant professor in the Department of Radiology and Nuclear Medicine at the Amsterdam University Medical Center in the Netherlands. She graduated from the University of Maastricht in neuropsychology and cognitive neuroscience and gained experience as a researcher at the Melbourne Neuropsychiatric Center in King's College London. Subsequently, she started a joint PhD project combining faculty at the Imperial College London and the Amsterdam Medical Center, in which she focuses on validating and applying pharmacological MRI approaches. As a translational scientist, she's conducted studies in animal models, human models of dopamine alterations, and a clinical trial in patients with ADHD, about which we'll hear. In 2018, she received her own grant to further develop her pharmacologic MRI methods and apply these to improve individualized care in psychiatry with a focus on ADHD and depression. And we're very glad to have her join us.
Okay, thank you very much for that kind introduction. I have nothing to disclose. Here's a quick outline of the talk, in which I will first introduce some research on ADHD medication and brain development, and subsequently discuss our translation of the animal literature into a clinical study, which I will share some results of. Psychostimulants, including methylphenidate and dexamphetamine, are generally considered the first-line management for the core symptoms of ADHD. As you also heard in the previous presentation, stimulants are very successful in reducing ADHD symptoms, as about 70% of patients report symptom reduction. Most of these medications work on the dopaminergic and noradrenergic system. And as you can see from this graph with data from the US, therapy with medication is actually already more prevalent than behavioral therapy from the age of 6 or so onwards. But if we look at that age range, we also know that the brain in general, and the dopamine system more specifically, are still in development during this period. And the timing of the onset of medication for many children with ADHD is parallel to the development of cortical areas, especially the prefrontal cortex. And interestingly, it has been observed that cortical maturation is delayed in ADHD, and that this delay is largest in prefrontal regions. However, it's also been shown that these trajectories remain relatively parallel, suggesting that these are non-progressive. On the other hand, it's been demonstrated that age can normalize this lag in cortical maturation. And this meta-analysis also demonstrated that medication, independently of age, can speed up cortical maturation, in the sense that stimulants seem to normalize the lag in cortical maturation. That's of course on a macro scale. So what happens when we zoom in? The dopaminergic system, which is thought to be affected in ADHD and is a primary target of the stimulant medication prescribed, also undergoes substantial maturations in the years that ADHD medication is prescribed. So for example, we know from animal studies that some dopamine receptor subtypes undergo substantial remodeling during adolescence. So what happens when you administer these medications acting on those systems while they are still in development? Well, a number of animal studies have demonstrated long-term effects of stimulants on the outgrowth of the dopamine system. So for example, early treatment with methylphenidate reduced dopamine transporter density shortly after treatment, but this effect was actually more pronounced when this was measured in adulthood, which suggests that it induces some sort of a rewiring or different outgrowth of the dopamine system. Additionally, early stimulant use has been shown to reduce dopamine D3 receptor expression in the prefrontal cortex, increase regional cerebral blood volume responses to subsequent challenges with methylphenidate, and depress cortical excitability. Behaviorally, it's actually shown to reduce sensitivity to cocaine, which can be considered a positive feature, but increase depressive-like symptoms, which are, of course, negative consequences. This was all conducted in healthy animals. This raises the question whether we also see such developmental effects in humans, and whether these findings can actually be translated to the clinical situation. So in an attempt to actually try and translate these findings from the animal literature to clinical research, our lab, led by Professor Reneman, set up a clinical trial. That was the ePOD study. We started with a randomized controlled trial, now coined the ePOD 1 study. And the aim of this RCT was to investigate whether stimulant treatment induced age-dependent effects on the dopamine system. And to this end, we included 50 stimulant treatment naive boys between 10 and 12 years of age, and 49 stimulant treatment naive men between 23 and 40 years of age. They were randomized to 4 months of methylphenidate or placebo. The length of this trial, so 4 months, 16 weeks, was dictated by the length of the waiting list to see a psychiatrist in the Netherlands at the time, because it would otherwise be unethical to withhold effective treatment, of course. Prior to randomization, subjects underwent an MRI scan, a neuropsychological test battery, and questionnaires. This was repeated again during treatment at 8 weeks, so mid-treatment, and subsequently 1 week after the end of treatment. So that was after a 1 week washout period. And this washout period is important because it allowed us to assess whether these effects persist for longer than just the acute effects of medication. After this RCT, we set up a naturalistic follow-up approximately 4 to 5 years later, in which we investigate more long-term outcome of these patients and its association also again with medication use. Participants again underwent an MR scan, neuropsychological assessments, and questionnaires. So here you can see the demographics of the sample at baseline and also at the final follow-up. At follow-up, we were able to include 34 children and 26 adults. And we found that those that participated in the follow-up did not significantly differ from those who didn't in terms of baseline characteristics. In the group that came back for the follow-up, we saw a significant decrease in ADHD symptom severity at follow-up compared to baseline, both in adults and children. So the main imaging technique that we use to attempt to measure the effects of ADHD medication on the dopamine system is pharmacological MRI. I'll briefly explain how it works. It's fairly similar to functional MRI, in which we provide a certain sensory or cognitive stimulus, which induces a neural response, and through neurovascular coupling, also a vascular response. This vascular response we can then measure with fMRI, typically with bold fMRI. For pharmacological MRI, instead of a cognitive or sensory stimulus, we provide a pharmacological stimulus, or a challenge, if you will. This pharmacological challenge will bind to its target receptor and elicit, again, a neural response, and through neurovascular coupling, also a vascular response. When we measure this vascular response, we call this pharmacological MRI. In our case, we used methylphenidate as a challenge in order to obtain a proxy measure of dopamine function. And we used arterial spin labeling to measure the cerebral blood flow response, so the vascular response here. So the main question was, is there an age dependency in a change in the pharmacological MRI response after methylphenidate treatment? So at our baseline MRI measurement, we use an oral methylphenidate challenge of 0.5 milligram per kilogram with a maximum dose listed here. We used an oral challenge for the pharmacological MRI response, which means that we obtain a CBF map, a cerebral blood flow map, prior to and 90 minutes after the oral methylphenidate dose, so at peak plasma levels. And the difference between the first and the second scan, we call the baseline pharmacological MRI response. So after 4 months of treatment, subjects underwent the same protocol and we obtained the post-treatment pharmacological MRI response. Finally, the change in this pharmacological MRI response from baseline to post-treatment is then our outcome measure. So first of all, we see that there's already an age-dependent effect in the pharmacological MRI response at baseline. So we observe a significant decrease in cerebral blood flow in children and adults in cortical areas. But the effect is actually more widespread in adults, as you can see here. In contrast, in children, we actually observe a larger effect of methylphenidate on thalamic CBF compared to adults. So for the main analysis, we focus on 3 ROIs within the frontostriatal circuit that have been hypothesized to be affected by methylphenidate. In the bar graphs, the children are displayed in gray and the adults in black, with the medication groups displayed side by side. We found specifically in the striatum that the pharmacological MRI response at post-treatment significantly differed compared to baseline in the children treated with methylphenidate, but not in the placebo children, nor in the adult groups. And in the thalamus, we found a similar response, but this was not different between the groups. And in the anterior cingulate cortex, we found no significant changes from baseline to post-treatment. When looking at clinical outcome, we see a different story. While in both children and adults, methylphenidate decreased clinical global impression scale during treatment, we see that in the children with methylphenidate, they don't differ anymore from the placebo group after the treatment ends, so after 1 week washout, whereas in adults, the methylphenidate group is still improved more than the placebo group. So it's possible that these neurobiological effects and clinical outcomes are not necessarily related to each other on a similar timescale, which is also supported by animal studies that demonstrate that behavioral effects of early medication are largest in early adulthood. However, from these results, it's difficult to conclude something about either positive or negative consequences of this 4-month treatment on the pharmacological MRI response. So in addition to the pharmacological MRI response, we also obtained different imaging measures and cognitive tests, of which I will also share some results. So we measured diffusion tensor imaging to assess white matter integrity, and we found increased factional anisotropy in several tracts in methylphenidate treated children, but again, not in placebo treated children or in adults. Similarly, we found reduced cortical thinning in the right medial prefrontal cortex in this group compared to other groups, which corroborates previous findings from Shaw et al. And for our cognitive measures, we actually did not find age differences. In both age groups, methylphenidate improved working memory and response speed, but not response inhibition, episodic memory, or delay aversion during the treatment, so at 8 weeks. However, these effects did not extend past the washout, so after treatment end. So for the follow-up, we were mainly interested in whether this baseline pharmacological MRI response would also be a good predictor for clinical outcome later on, and if this was moderated by medication use over time. So for this, again, we took the baseline pharmacological MRI response and built a statistical model in which we included cumulative stimulant dose as a moderator. As an outcome, we used the change in ADHD symptoms from baseline when subjects were completely medication naive to follow up 4 to 5 years later. First of all, it's interesting to note that in children, there does not appear to be a strong effect of the cumulative medication dose in itself on the change in ADHD symptoms from baseline, whereas this effect does seem to be present to some extent in the adults. And something happened. Okay, let me start that again. Can you see my screen?
Yes, but you're on the first slide.
Yeah, cool. All right, I'll go back to the one I was talking about and then I'll repeat that one again. Okay. Subsequently, we investigated the relation between the pharmacological MRI response, which you can see on the x-axis here, so the change in cerebral blood flow, and the change in ADHD symptom severity on the y-axis. Again, we here present the data from ROIs that we also used for our original ePOD 1 study. The size of the dots here indicates a cumulative medication dose, but the R² and the p-values here represent only the simple regression between the pharmacological MRI response and the severity change. And as you can see, we observe no significant association in any of the groups or areas, although we do observe some trends here where we can see that the anterior cingulate cortex pharmacological MRI response might be predictive of outcome in children. And indeed, when we do include cumulative medication as a predictor in the model, we do observe that the pharmacological MRI response becomes a significant predictor of change in symptom severity. However, as the interaction effect was not significant, medication cannot be considered a significant moderator in this model. So to summarize, we found evidence for short-term, age-dependent, persistent effects on methylphenidate on pharmacological MRI response, but this effect was not associated with the clinical outcome at the time. These effects are after a short washout period, a short treatment period of 4 months and a short washout. More long-term retrospective studies did not find evidence for effects of medication on brain development, as was shown by another group from the Netherlands. And although these studies are hard to compare because we use pharmacological MRI, which presumably measures changes to underlying neurotransmitter systems, and they used fMRI, we included medication-naive children, and they included a mix of medication-naive and non-medication-naive children. It seems that although in the short term stimulants can affect brain circuits, there's currently no evidence that this persists in the long term. As for predicting clinical outcome, we found that the baseline pharmacological MRI response in the ACC could predict long-term ADHD symptom severity in children when cumulative medication dose was taken into account. This suggests that the baseline pharmacological MRI response as a proxy of the dopamine response can be informative of subsequent outcome. And the reason that this might be the case could be that it has some prognostic value, could be because it's possibly predictive of the maturation of connections in the frontal striatal circuit. Other studies that investigated the effect of medication on later outcome show mixed results. For example, based on the MTA trial and some other studies, it was concluded that medication has beneficial effects on the short term, up to 2 to 5 years, but that there's no evidence that treatment changes functional outcome later in life. However, Biederman et al. Recently came to a different conclusion based on 3 large studies that they ran, namely that early stimulant treatment has a protective effect in that it reduced a risk for mood and anxiety symptoms, addiction, and academic failure. However, the reasons for these different findings still warrant some further investigation. Of course, we also had some limitations to our studies. Our sample size, particularly at follow-up, was rather small, and we included only male subjects. And another limitation to our study is that we used the cumulative medication dose that we obtained from pharmacy records, as we could not verify adherence, and therefore this is an estimate, of course. Additionally, the question would also be whether cumulative medication dose is the best predictor, or whether we should consider timing of dose, mean daily dose, or another variable. As for future steps, we want to analyze also the pharmacological MRI data that we obtained at follow-up. We want to investigate the association with other functional outcome measures such as quality of life, and we will commence a 3rd follow-up when the kids have reached 18 to 19 years of age. So for future neuroimaging work in general, I would recommend to have a focus on markers that can help us tailor the treatment to the individual, for example, by improving our biomarkers and or combine this with radiomics and AI. To improve our biomarkers, I think that functional assessments are probably the most promising, although they would be hard to standardize across centers, of course. Additionally, pharmacological MRI data presented here suggest that these challenge assessments could be very useful. Similarly to cardiovascular assessments in which exercise is used as a stressor to uncover irregularities in the ECG, for example, we can use perturbations of our neurotransmitter systems or functional systems to assess these systems best. So we can think of different types of perturbations, either with like a task or with medication, as shown here. In addition, the use of multimodal assessments could prove very beneficial. And using radiomics or AI, we could use these different modalities to predict outcome. But we could also add clinical variables, physiological variables like sleep patterns or cognitive test outcomes as additional features. Nevertheless, and I cannot stress this enough, we need good and reproducible imaging data in order to accomplish this all, which can of course be facilitated by open science. And so far the future, for now, I would like to thank all the patients and the people working on these projects and our funding bodies. And furthermore, I would like to say that I'm very grateful to the SOBP and especially also the organizers of this symposium for giving me the opportunity to present my work here. Thank you very much.
Thank you, Anouk. Now let me take the opportunity to present our next speaker, Dr. Jessica Cohen, an assistant professor in the Department of Psychology and Neuroscience at the University of North Carolina at Chapel Hill. Jessica received her PhD at the University of California, Los Angeles with a focus on cognitive neuroscience. She completed her postdoctoral training at the University of California, Berkeley, and Kennedy Krieger, Johns Hopkins. Her research uses behavioral neuroimaging and clinical approaches taken from neuroscience, psychology, and mathematics to investigate how functional brain networks interact and reconfigure when confronted with changing cognitive demands, when experiencing transformations across development, and when facing disruptions in healthy functioning due to disease. Dr. Cohen is currently conducting research probing how the maturation of functional and structural brain networks across the transition to adolescence relate to clinical outcomes in youth with ADHD, as well as how baseline brain network organization can predict treatment response in medication-naive children with ADHD. So, Jessica, the podium is now yours.
Well, thank you, Victor, for that, and Javier for inviting me to be a part of the symposium, and Javier for this kind introduction. Can I start again? I now feel very flustered because I called you the wrong name, Javier. Sorry about that. Okay. Well, thank you, Javier, for that kind introduction, and to Victor and Javier for inviting me to be a part of this really exciting symposium. It's been great hearing the talk so far, and I'm looking forward to presenting data from my lab, where I'll be talking about dynamic reconfiguration of functional brain networks in ADHD after methylphenidate administration, how that relates to improvements in response control. So I just want to start by saying I have no conflicts of interest to disclose, and that this work was funded by the National Institute of Mental Health. So over the last 5 to 10 years, a handful of review papers have been published discussing the idea that ADHD may emerge from disrupted patterns of functional and structural connectivity. Very generally, individuals with ADHD tend to have greater local connectivity and reduced long-range connectivity. So for example, this schematic is showing that there is reduced small worldness in ADHD, which is driven by increased local clustering of connectivity or greater local efficiency, as well as increased characteristic path length or reduced global efficiency. Stimulant medications, which are often considered a first-line treatment of ADHD, have been shown to alter functional connectivity even after a single dose. So during attention and cognitive control tasks, stimulant medications have been shown to increase frontostriatal functional connectivity, as well as default mode network to task positive network anti-correlations. And there's evidence that this functional connectivity is normalized with respect to typically developing children on stimulants. And during a resting state, it's been shown that stimulant medications result in extensive changes really in functional connectivity distributed throughout cortical and subcortical regions. Critically, however, as both Anna and Anouk have mentioned in their presentations, stimulant medications are not uniformly effective. So they tend to alleviate symptoms in approximately 70 to 80% of individuals. But if we could predict who would respond to stimulants before beginning a course of treatment, we could greatly increase our efficiency and also our efficacy in treating symptoms of ADHD. So the connectome may be a promising candidate for successful prediction of treatment response. It's been found that baseline functional connectivity predicts treatment response across populations and interventions. So as an example, in patients with traumatic brain injury, it's been shown that whole brain modularity at baseline predicts improvement in attention and executive functions after cognitive training. It's also been shown in patients with obsessive compulsive disorder that baseline functional connectivity patterns within the default mode network and the visual network have been shown to predict reduction of OCD symptoms after treatment with cognitive behavioral therapy. And as a last example, in patients with schizophrenia who are being treated with antipsychotics, baseline connectivity within the default mode network, which is shown in this top panel in the red connections, as well as between the default mode network and the salience and the somatomotor networks, which are shown in the blue connections, have been shown to predict reduction in positive symptoms of schizophrenia after treatment. So given all of this literature, the goal of the current study was to determine whether features of the functional connectome relate to improvement in cognitive control after treatment with methylphenidate in children with ADHD. Our participants were 24 medication naive children with ADHD who were between the ages of 8 to 12 and fairly evenly balanced in gender, and 25 typically developing children who were age, sex, and IQ matched. All of the participants completed 2 testing sessions approximately 1 week apart. For the ADHD subjects, they underwent a medication challenge, so a double-blind randomized placebo-controlled crossover challenge where they were administered either 0.3 milligrams per kilogram of methylphenidate or a placebo approximately 1 hour before the MRI scan. And for the typically developing subjects, they completed 2 identical sessions without a drug intervention. Each of the sessions included a 12-minute resting state scan, as well as a go, no-go test to assess behavioral response control. And in our version of the go, no-go task, subjects saw a series of sports balls, as you can see here, and they responded with a button pressed to the go balls, which were approximately 80% of trials. And then they withheld their responses to the no-go balls, in this case, a tennis ball as an example. We use standard pre-processing for our data with fMRI prep. We included 32 nuisance regressors, which includes 6 motion parameters, white matter, and CSF, as well as their derivatives, quadratic terms, and the squares of derivatives. We also used a standard bandpass filter, and we added on top of that a respiratory notch filter, given recent evidence that movement of the magnetic field during respiration can artificially impact frame-wise displacement estimates. And our scrubbing threshold was a frame-wise displacement of greater than 0.2 millimeters. And we also excluded any portions of time points that had fewer than 5 contiguous good ones. And our subjects were excluded if fewer than 150 time points were remaining after scrubbing. We did not see any differences in mean frame-wise displacement or motion in the scanner across the groups. So to create our brain graphs, and really to create brain graphs generally, but I'll talk about how we did it, the first thing you have to do is to define the nodes of the graph, which we defined as functional brain regions distributed throughout the entire brain. And on the next slide, I'll talk about the very specific atlas we used. But once you define the nodes, you then have to define the edges of the graph, or the connections between the brain regions. So what this plot is showing is the fluctuations in bold response that occur across time in one of the red regions and one of the blue regions. So these 2 time series. And the edge definition that we used was time series correlation. So we simply correlated the time series of these 2 regions, and the correlation magnitude is considered the functional connectivity strength between that pair of regions. Now, you then do this for every pair of brain regions to create a connectivity matrix or a correlation matrix, where each row and each column is one of the brain regions or one of the nodes of the graph, and each cell is the strength of the correlation or the functional connectivity strength between each pair of regions. And I lined these regions up by colored network, so red, blue, and purple. And the reason I did that is because I just really wanted to point out that in all brain networks, and really in any naturally occurring network, what you see is stronger within network connectivity and weaker between network connectivity on average. So once we have a correlation matrix, you can create the brain graph, where each of these circles is one of the nodes of the graph, and here it's plotted in brain space. So each region is depicted where it falls in the brain, and the lines connecting the regions are the edges or the connections between the brain regions or the nodes of the graph. And the way the coloring is, just to kind of orient you to future images, each color represents a network. So there's the purple network, which is an occipital network, and then the red and the blue networks. Each colored edge represents a within network connection, and each gray edge represents a between network connection. So this is depicting the network in brain space. Another way that you can depict the network, which I will do in a future slide as well, is in connection space. And in this case, nodes that are more tightly interconnected are depicted as closer together. In connection space, you can't tell where in the brain these regions fall, but a nice thing about connection space is you can really tell that these networks have this strong within network connectivity. And while there are connections across networks, they're fewer and further between. So the regions of interest that we use were from an updated version of the Power Functional Brain Atlas that has better subcortical coverage. And we focused on networks that have been found to be disrupted in ADHD. So we focused on cognitive control networks, including the frontal parietal network and the singular opercular network. We also looked at the default mode network, the reward network, and the somatomotor network. We calculated 3 different metrics to assess network topology. First, we calculated modularity, which is a whole brain measure that assesses the overall segregation of the brain into distinct modules or networks, which are depicted by these gray ovals. We also calculated within module degree, a nodal measure that characterizes the strength of within network connectivity of a node. So this red node circled in yellow, for example, has high within module degree. We averaged across all nodes within a network to get network level averages of within module degree, and this assessed within network coherence. Finally, we calculated node dissociation index, also a nodal measure that characterizes the connectivity of a node, but this time outside of its network. So this blue node circled here has a high node dissociation index compared to the other nodes in this graph. And once again, we averaged across all nodes within a network to get network level averages of node dissociation index to assess a cross-network integration. Behaviorally and on a group level, we found that methylphenidate significantly improved response speed, so mean reaction time, with a trend toward improving accuracy as indexed by D prime. We also found, however, that methylphenidate did not significantly improve response variability on a group level. And the index of response variability that we used was coefficient of variation, or CVRT, which is calculated as the standard deviation divided by the mean reaction time to control for baseline differences in mean reaction time. However, if you look on the individual subject level, you see that there's a lot of inter-individual variability in terms of the magnitude of improvement. So while many subjects do improve on drug, you can also see that some stay about the same and others perform worse. So here I visualized the brain graphs depicting average connectivity for each of the 2 sessions in the ADHD subjects. And for ease of interpretation, I've only included nodes and connections related to the networks of interest. So the frontal parietal network, the singular opercular network, the default mode network, the reward network, and the somatomotor network. So this brain space view is nice because you can see how the networks are distributed across the brain, but it's also a bit hard to tell differences in overall connectivity between the placebo and drug sessions. So I've also plotted the graphs in connection space, which once again depicts nodes that are more strongly interconnected as closer together. And in connection space, some of the differences across the sessions become more clear. So as an example, the default mode network in red and the frontal parietal network in yellow are more interconnected with each other during the placebo session than during the drug session. And the singular opercular network in dark purple and the somatomotor network in cyan are more integrated with each other during the drug session. And for the reward network in lavender, it's a little hard to see because there aren't very many nodes, but it seems relatively similarly integrated, at least on the group level, across the 2 sessions, with connections distributed across multiple networks. However, just as there were many individual differences in change in behavior on and off drug, what I'm most interested in is change in connectivity on and off drug on the individual level. So we investigated whether methylphenidate induced change in network organization on the individual level related to improvements in performance on the go-no-go task. We did this by subtracting both network metrics and behavior assessed on the drug day from network metrics and behavior assessed on the placebo day. And we did this separately for each subject. We focused on response variability, or CVRT, and accuracy, or D prime, because these are metrics that are most consistently impaired in ADHD. So first I'm going to show you the axes without data, since I'm plotting different scores so it's clear what they're depicting. On the x-axis, I've plotted the change in the brain metric. And since I'm subtracting the drug day from the placebo day, positive values indicate that the metric was larger during the placebo day, and negative values that it was larger during the drug day. And then on the y-axis, I plotted change in behavior. So in this case, change in CVRT. And so here, positive values indicate that participants performed better on the drug day because a reduction in CVRT indicates more stable responding. And negative values indicate that participants performed better on the placebo day. And so I plotted the same data for D prime, but since higher D prime indicates behavioral improvement on drug is now plotted with negative values on the y-axis, and better performance during the placebo session will be positive. So first we looked at whole brain modularity, and we saw no relationship between change in modularity on drug and change in behavior for CVRT or for D prime. So next we looked at the network level properties of within module degree and node dissociation index. When focusing on within module degree of the task relevant networks, we found with regards to CVRT that if within module degree of the singular opercular cognitive control network decreased on the drug, then CVRT decreased as well. So in other words, responses became more stable. With D prime, we found that if within module degree of the reward network decreased on drug, then D prime increased. So responses became more accurate in addition to becoming more stable. When probing node dissociation index of the task relevant networks, we found with regard to CVRT that if node dissociation index of the frontoparietal cognitive control network decreased on drug, then CVRT decreased or responses became more stable. And if node dissociation index of the reward network increased on drug, then D prime increased, or subjects became more accurate with increased node dissociation index. As an interim summary, these results show that the degree of change in topology of task relevant networks relates to the amount of improvement in go, no-go performance. So the whole brain change in topology was unrelated to improvement on the go, no-go task. With regard to cognitive control networks, however, we found that decreased within network connectivity of the cingulo-opercular network and decreased inter-network integration of the frontoparietal network related to reduced response variability. And with regard to the reward network, we found that decreased within network connectivity and increased inter-network integration related to improvements in accuracy. We next assessed whether baseline symptoms predicted network changes. And we looked both at change in whole brain modularity and also at node dissociation index of the reward network and how they were predicted by ADHD symptoms. So in these plots, I'm plotting symptoms on the x-axis and then the change in brain metric on the y-axis. And so for symptoms, these are from the Connors parent report, and we're reporting the raw score on the subscales, in this case, inattention subscale. And the y-axis, we're plotting the change in modularity, in this example, change in the brain metric, with positive values, again, indicating that modularity was higher during the placebo session and negative that it was higher during the drug session. So what we found is that in the subjects who had higher baseline levels of inattention, there was a greater increase in modularity on the drug as compared to on the placebo, or on the drug. And when we looked at reward network node dissociation index, we saw that those with higher baseline inattention showed greater decreases in node dissociation index on the drug. We also looked at hyperactive impulsivity symptoms, and we see a similar trend at the whole brain level in terms of modularity, where higher baseline hyperactivity and impulsivity tended to be related to greater increases in modularity on the drug. And we did not see a significant relationship with node dissociation index of the reward network, but it was in the same direction as it with inattention symptoms, which is that higher baseline hyperactivity and impulsivity was related to greater decreases in node dissociation index on the drug. So this study demonstrates that methylphenidate improves response control in some, but not all children with ADHD, and that the degree of change in topology of task-relevant networks relates to the amount of improvement in go, no-go performance. The changes in the cognitive control network topology underlie reductions in response variability, or CVRT, and changes in reward network topology underlie improvements in response control, or D prime. We also showed that baseline characteristics, in this case symptoms, predicted who would have larger changes in network organization on drug. And our next steps with this data set are to determine whether baseline network topology can improve outcome prediction above and beyond the baseline clinical characteristics we've already looked at. Together, this indicates that we may be able to use network topology as a biomarker for methylphenidate response to ultimately better target treatments toward individuals. And I'd like to end by thanking, of course, the participants in our study, as well as my lab members, especially those who are part of this project. So Cheyenne Bricken, Kelly Ohm, Nick Fogelman, Teague Henry, and Mackenzie Mitchell, as well as my collaborators with those highlighted here who were involved in this project, Diana Sajas, Laura Polite, and Margaret Sheridan. I'd also like to thank the NIH for funding this work, and of course, Society of Biological Psychiatry, and Victor and Javier for inviting me to be a part of this symposium. Thank you.
Thank you so much, Jessica. It's really fun to see that come together. And again, I look forward to having a brief discussion about all this following the next talk. And so let me take the opportunity to introduce the co-chair and the driving force behind putting the symposium together, Victor Pereira-Sanchez. Dr. Pereira-Sanchez is a fellow of the Fundación Alicia Kaplowitz and clinical instructor at the NYU Grossman School of Medicine in the Department of Child and Adolescent Psychiatry in New York. He received his MD and specialty training in psychiatry at the University of Navarra in Spain. During his clinical training, he enrolled in a PhD program in biomedicine and conducted research harnessing resting state fMRI with the goal of identifying potential biomarkers of treatment response to medications in children and adolescents with ADHD. While a resident, he proposed a study, obtained pilot funding, and successfully recruited a sample of boys and girls in Spain with ADHD. He's currently conducting the imaging analyses at NYU with my support and in close collaboration with colleagues at the Center for the Developing Brain at the Child Mind Institute. He's also involved in international networking and research efforts linking early career psychiatrists from throughout the world. So let me turn the podium over to Victor.
Good morning from New York. Thank you very much, Dr. Castellanos, for the kind introduction, and SOBP for enabling this online alternative to present our work. I feel grateful for the opportunity of presenting for the first time in a symposium the results of my first work in neuroimaging among a panel of outstanding colleagues. My talk will show an application of resting state of MRI for the analysis of the effects of stimulant treatments on a small sample of children and adolescents with ADHD, which I collected during my psychiatry training years in Spain as part of the CONMED study at Clínica Universidad de Navarra. I have no conflicts of interest. My current training program is funded by a nonprofit foundation to support the development of child and adolescent psychiatry in Spain. This study was mainly funded with research funds from our Department of Child and Adolescent Psychiatry in Spain. This presentation will follow a standard format focusing on the key methods and network statistic results, providing a preliminary interpretation for them. Clinical and neurobiological research evidence support the conceptualization of ADHD as a neurodevelopmental disorder, which core symptoms start during childhood and tend to persist during the lifespan with different degrees of impairment. For many years, pharmacological treatments have been used to address these symptoms and improve functional outcomes. Those treatments, particularly stimulants, are thought to mainly enhance the flow of dopamine and noradrenaline in frontostriato-parietal circuits, which are presumed to be dysfunctional in patients with this disorder. However, little is still known about the neurobiological basis of the disorder and the effects of treatments. Resting state functional magnetic resonance imaging, or fMRI, based on the analysis of ball signal fluctuations across the brain to reveal maps of functional connectivity in a resting state condition without requiring specific tasks, emerged about 2 decades ago as a promising tool to discover intrinsic brain activity biomarkers of neuropsychiatric disorders, and has been extensively used in ADHD research. Our fMRI research on this disorder has particularly focused on the study of brain networks. Studies comparing samples of children, adolescents, and adults with ADHD with age-matched control individuals has pointed at the potential dysfunctions in local and long-range intrinsic functional connectivity of several brain areas and networks. The activity of the default mode network, the DMN, has been highlighted as a prominent disruptor of the normal functioning of attentional and executive networks, potentially explaining some of the core symptoms of patients. Furthermore, a still small and highly heterogeneous sample of studies on resting state of MRI assessing the effects of pharmacological medications has suggested the possibility that normalization of intrinsic functional connectivity abnormalities may be correlated with clinical improvements in response to treatment. However, resting state of MRI research on ADHD, especially studies investigating medications, is still a science in development, challenged by limitations in sample sizes and frequent exclusion of females. Also challenged by the effects of motion artifacts and the need for reliable multiple comparison correction methods. In addition, the clinical relevance of studies using medications is still limited due to the frequent use of experimental treatment schemes which don't capture the real-world use of medications, and also due to the frequent restriction of imaging analysis to pre-specified regions of interest, potentially biasing results and overlooking other brain areas and networks. With this background, our study aimed at analyzing the resting state network patterns of connectivity in boys and girls with ADHD in a clinical sample, naturalistically treated with the stimulants, and with good responses. We wanted to compare the differences between responders to methylphenidate and lisdexamfetamine versus treatment-naive individuals, and to explore potential differences between responders to those two treatments. An overview of the study workflow, which is common with any resting state fMRI study, is presented here. A series of important steps are required to ensure acquisition of good quality data to be compared across groups. I will point out some of the relevant details in the next few slides. We recruit a small convenient sample of boys and girls with ADHD between 7 and less than 18 years of age. Patients were included in 3 groups. The first was composed of patients in long-term treatment with methylphenidate with good clinical response. The second included patients who had not responded to methylphenidate, but with current good response to lisdexamfetamine and treated for a comparably long period. The third was of patients without past exposure to treatments, usually at the first day and time of initial diagnosis before starting any treatment. The criteria for defining treatment response was consistent with previous research and based on both parental and clinical reports. The key exclusion criteria for participant selection are listed at the bottom of the slide. We acquired around 8.5 minutes of resting state of MRI data with the scanner, settings, and sequences presented on the slide. Participants were instructed to lay still, awake, and with eyes open. The tolerance to the scanning session was generally good in spite of the young age of some participants. Regarding preprocessing methods, we configured a customized pipeline using the open source software CPAC. We conducted anatomical processing with advanced normalization tools and used robust methods to minimize noise, especially from head motion. We extracted the time series of the 10 networks identified by Smith et al. In 2009 for dual regression analysis. Quality control was conducted on the preprocessing outcomes to exclude images and subjects with low quality data. These are the 10 networks for which time series were extracted through dual regression based on the work of Smith et al. In 2009. These include the 3 visual, default mode, cerebellar, somatosensory, auditory, executive control, and bilateral frontoparietal networks. As for group comparisons, we use a cross-sectional analysis of the functional connectivity across networks, setting a matrix to include the connectivity of each of the 10 networks with all the others. We use the network-based statistic tool in MATLAB. Our primary contrasts were between the 2 groups treated with the stimulants, both separately and combined, against the treatment-naive group. A secondary contrast compared the 2 treated groups to each other. Multiple comparison correction was conducted with a false discovery rate method using permutations. This table shows the phenotypic characteristics of subjects across groups. A total set of 55 subjects was included, and after quality control. Age was between 12 and 14, younger for the treatment-naive group. Girls were overrepresented versus boys only in the methylphenidate group. Symptom scores were higher in those who were treatment-naive, as the other groups were by definition already responsive to medications. The medicated groups have been treated for a median of around 23 to 26 months. The 3 groups were comparable in head motion parameters and the amount of data available for the final analysis. The across-group comparison of the cross-network functional connectivity showed a statistically significant reduction in functional connectivity between the lateral visual network and the executive control network in subjects treated with the stimulants versus treatment-naive individuals. The mean functional connectivity in all groups between these 2 networks was negative, and those with stimulant treatments showed an increase in this anticorrelation. These differences remained statistically significant when comparing only patients treated with dexamphetamine versus treatment-naive, but not when comparing only those with methylphenidate versus treatment-naive. Finally, the comparison between both treated groups yielded no statistically significant results. It's worth noting that our preprocessing did not include global signal regression. As depicted here, the lateral visual networks correspond with lateral occipital areas, whereas the executive control networks cover several frontal and medial frontal areas, including the anterior cingulate and paracingulate. Our preliminary results suggest a strengthened anticorrelation of lateral visual and executive control networks in children with ADHD responding to stimulants after a long-term treatment versus treatment-naive patients. This finding is consistent with increased segregation between 2 networks, for which interference might lead patients with ADHD to have difficulties suppressing visual distractions in the exercise of executive tasks, as some authors have suggested when discussing hyperactivation of visual areas in patients with ADHD. This may also reflect a compensatory mechanism by patients to rely more on sensory areas due to the impaired function of attentional and executive control areas. I want to emphasize that these results should be interpreted with caution, mainly to the small samples included in the study, as well as the lack of a healthy comparison sample. Analysis of this QMed study data are continuing as part of my postdoctoral fellowship training and may take advantage of other statistical techniques and from the use of other multimodal data we acquired, specifically on brain iron and arterial spin labeling data. In conclusion, we found preliminary evidence compatible with a possible reduction of visual executive control network interference in subjects with ADHD after a successful long-term naturalistic treatment with the stimulants, particularly lisdexamfetamine. Although these results should be considered preliminary, they suggest that analyzing the effects of medication on whole brain network patterns in naturalistic samples might be of value as we seek to understand the therapeutic mechanisms of psychiatric medications. Here are the key references that I have mentioned. I want to express my gratitude first to the young participants of this study and their families. Secondly, to all the contributors of this study, especially the principal investigators and their recruiting and analysis collaborators. And finally, to the funders of the study and of my research and clinical activities, particularly to the Alicia Koplowitz Foundation. Thank you very much for your attention. Feel free to reach out to me in case you have any questions. My contact details are provided. I really hope and pray that you stay safe these days, and I look forward to the opportunity to meet you in person soon. Thank you very much.
Thank you, Victor. Wonderful. Thank you all for your extraordinary contributions. As I said at the beginning, I'm honored to be a part of this and to serve as the presenter of your work and you to the wider community. And I anticipate that your career trajectories will continue to make headway in this challenging undertaking of understanding how the brain works and how we can optimize it by using the tools of neuroscience. Let's take a few moments to reflect on where we are as a field, and this puzzle of, on the one hand, having medications that are reasonably safe and reasonably effective, and as is often the case in the brain especially, the continuing uncertainty as to mechanisms. What seems to be emerging from your work is a sense that we're now able to start putting pieces together, start following avenues that may be providing us with hypotheses that we can continue to refine and test. And so I'd like to throw open a couple of questions to each of you. One is, and again, most of you have already mentioned this about where you're headed sort of next with your work, but I'd also like to have us think about where you're going even 2 steps beyond, and how likely is it that very difficult to do, but still, how tentative do we need to be, and how confident can we be that we're, as a community, coming together in terms of understanding how to use our tools to proceed. And I think you're the senior in this group of presenters. What do you think?
Well, it's a difficult question, right?
Yes.
I wish I had a good answer for that. But yeah, it is exciting. It is exciting to see that we have brand new tools, right? So for example, Anouk was highlighting something that I think is really important, right? We need to find helpful biomarkers, and possibly the use of multimodal measures will help us to get there, right? I think, for example, that's something to highlight. And also the use of network analysis, I think, is extremely promising. It is something that is coming now, and I can see the usefulness of this. We can go back, instead of trying to classify patients by symptoms, let's say, or by how they are behaving in certain tasks, we can do the other way around. How did they differ in all these neurobiological measures, and how that can help us to better classify the symptoms and the responses in different cognitive tasks, and therefore what may be best in terms of medication for them, right? How far are we from being able to apply this in the clinical setting? But we're still far, obviously. But all these steps are small steps that a decade ago were not even something we can think of, right? And I still remember when I first started pre-processing analysis, every pre-processing with a participant would take you easy a day or two. And now it's like, there's no time. So the advance in methods, and how, for example, I'm very excited with this network analysis, and I think it's really fantastic, and it's something that will develop much faster, and our progress will be much faster than what we have seen before. That's what I would anticipate. So maybe we are closer than we think to applications in the clinical environment, but we still a way to go. There is a lot of work needed. So hopefully we can continue working on it and making progress.
Thank you. Anouk, what are your thoughts?
Yeah, I agree with all that Anna has said here. What I would like to add is that I think that all of us are gathering great data sets, and we somehow have to find a way to actually harmonize and bring all these findings together. And I think we still have to think of ways to be able to actually compare these data sets. As we all know and have all experienced when pre-processing our analysis, but also doing the statistics, even though there are now tools that allow us to harmonize these processing pipelines, I think both on the acquisition side and on the processing side, I think we have to find a way to actually still be able to compare these differences. And a recent paper that I think came out in Nature recently, that compared 50 different ways of pre-processing and analyzing fMRI data, did actually point towards some regions that were truly activated in all of these methods. So I think that would be something that we could also try with functional assessment and functional data that we have in the future, I think, for research in ADHD as well. Yeah. But it's difficult, and I think it's one of the big challenges for the next decade or so, how to integrate all these findings and see if we can find a clear story there.
Great. Jessica, you've been looking at networks, and you made the point that many of your whole brain results were not revealing, but when you focused on particular task, networks that you had high priority to examine, that seemed to be more the case. Tell us more about that.
Yeah, I think it's, well, in part a combination of how people think the brain is organized, which is that there are many different ways to get to, say, excuse me, a modular structure. So a specific modularity value may look very different in, say, you than in me. And so I think when you look on the whole brain level, that it might miss some of the nuances. And so, we see when we focus on these networks that theoretically and also empirically, we know are impacted in ADHD, you do see that they have impacts on behavior. They're related to symptomatology and different patterns of symptomatology. And those also are the networks that seem to be most targeted by the drugs that alleviate symptoms. Excuse me, I have a tickle in my throat. But I do think that with some of the new network analysis tools, including the network-based statistic that Victor used, it's allowing us to define these whole brain graphs with a ton of variables. There's, hundreds of nodes, hundreds of thousands of edges, and be able to summarize all that without losing the individual information by appropriately correcting for multiple comparisons. And also with the high computing power we have, like Anna was talking about, you can do this in hours instead of weeks. So.
Yes, No, that's the one thing we have going for us, is that computational power continues to improve. And without that, none of this would be possible. So that's really something that has made this field and many other similar fields really gives us our driving force. So it's gratifying that we have that. Everything computationally gets better and more challenging and more complex, but more powerful. Victor, you've been working with a data set that was remarkably it was remarkable to get while you're busy being a resident, etc. And I know that you've been working on this as really an educational process. What are your thoughts about, besides the additional analyses you have left to do, where you'd like to see yourself moving, when you start to acquire the next set of data? What have you learned from this process?
Yeah, so yeah, this has been a very hard process. Well, it's still ongoing. For the first years, well, and I'm still feeling like an alien in the field, having a more clinical background. Because I remember going to my mentor in Pamplona. The first time I met him, I was in med school, and I say to him, "Hey, I want to do a project on neuroimaging of ADHD," and he was saying, "Okay." It's the first student with that idea. But yeah, over the years we were able to conduct this small study, and yeah, I was pretty much excited about papers I have read. So yeah, I want to see now, these nice images of the brain. But the first things I had to learn is that I needed to learn to program a little bit. I needed to learn a lot of small steps before being able to get these images I now presented after so many years. So I think personally I'm not, well, many skills can be learned. I'm not I will not probably be the best programmer and the best skill man with many technical issues, but I think what I have I think what is valuable in my background is that I was able to work with very closely with the children I included in my study. I was able to understand the whole process of conducting neuroimaging study, but most importantly, I was able to see the improvements in the children of my study. So I see myself more in a position where I can try to link the clinical work and the perspectives of clinicians with those who are more basic neuroscientists and more experts on neuroimaging, and try to fill this gap, because sometimes I perceive, especially in some of the previous research, that those worlds are completely separated, and then sometimes neuroimaging studies are not directly linked with clinical clinical outcomes. So we need to talk more and to move this field forward for the benefit of patients. And finally, sorry to extend, but a last thought, because in the last few days we saw an editorial in a neurological journal. I won't mention the name, but it's known. But it was saying, well, it was very skeptical with fMRI research, and one of the things it was saying is that it's a shame that fMRI is taking the efforts and taking the talent of young researchers into a field that is not having, has no potential, or so this symposium, hearing each of my colleagues here, is a complete rebuke of that, I think, and I encourage you to keep working with that enthusiasm.
Yes, it's always hardest to make progress in early stages, and that is where we are. We're science and development. Let me take the chair's prerogative to mention that Victor will be applying for postdoctoral fellowships in about a year. And so if we were at the New York meeting of the SOBP, I'll be introducing him to my colleagues, but I'll take this opportunity to say he's extraordinary clinician, physician, scientist that I anticipate will again follow the kinds of successful paths that the other presenters have already embarked on. With that, I'm thrilled to bring this to a close and to thank all of you, to thank the Society of Biological Psychiatry in its 75th year for being an organization that truly has sponsored and supported the development of the science of brain in psychiatric neuroscience. And thanks to all of you, and thanks particularly to Victor for being the driving force of this symposium.